Yep. So I lived not in that neighborhood, but close-ish to that neighborhood, and I would see Castro and his wife at Whole Foods all the time, and I'm like, like this, like, oh, I don't know you. Okay. All right. Well, happy Wednesday. We're getting there. It's gonna be a nice 3-day weekend. I totally forgot, so thank you, Adrian, for reminding me. I'm very excited. So, woohoo. So I want to wrap up with the immune response to infectious agents and vaccination. And then there are 2 sections, one on like general bacteriology and one on diagnosing and treating bacterial infections. Those are mostly going to be a review of your bacteriology class, but in case you're not like super refreshed on those, I've taught this class online before, so I have recorded lectures for those 2 sections that I'll link, and you can watch them if you want the refresher. But otherwise, after we finish vaccination, we'll move on to the actual bacteria themselves. So when we have an infection, it really depends on the type or the class of infectious agent, how the body is going to react. Sure, we have our innate immune system that broadly reacts to infection, but there are different aspects of the innate immune system that are more important for certain kinds of infection than for others. So something like complement, right? That idea of punching holes, right, in the cell membrane is really great for extracellular bacteria. It works okay for parasites, but it doesn't work against intracellular bacteria because they're inside the cell. It doesn't really work for viruses. And it's not great against fungi. Fungi have a completely different structure on the outside than bacteria do. Interferon can be turned on in response to intracellular bacteria, but interferon is really, really important against viruses. Okay. Phagocytic cells, again, as you might imagine, bacteria, extracellular bacteria. Phagocytic cells can also be at least neutrophils that'll, like the granulocytes for viruses, fungi, and parasites. Macrophages will eat anybody. They're not going to discriminate. Natural killer cells, right? They want that intracellular virus. And then when we get into our innate immune responses, you see that T cells are important for, helper T cells are important for all different kinds of infection. They may be more important or less important depending on the kind of infection. And then our cytotoxic T cells, you'll see they're really only important, our CD8 positive T cells are really only important if we have an intracellular pathogen, either an intracellular bacterium or a virus, because those cytotoxic T cells are going to tell the cell that it should undergo apoptosis. And if it's not infected with anything, you don't need that. So anything that hangs out outside the cell, we don't really use that cytotoxic response. And then antibodies can be important for all of them, least important for intracellular bacteria. As we talk more about some of the different kinds of bacteria, and we talk about how they move from cell to cell, there are lots of bacteria that don't even actually need to leave one cell, like go into the external environment to go to the next. They can push their way from cell to cell without ever going outside. And that can hide them from antibody, so antibody isn't always that important. And again, I'm not going to ask you the details of an image like this, but the response to a bacterial infection is complicated. You have your innate responses that come into play during the first 4 days, 5 days or so. And after about 6 days, that's when you start to get those antigen-specific responses. And you can, if you follow along with the image, the hot pink cells are innate cells, macrophages and dendritic cells. Your T cells are outlined in black, so you have like helper T cells over here. You have helper T cells, different kinds of helper T cells. And then you have, because this is antibacterial, you don't really have a ton of CD8 positive, but you can have some. But mostly those CD4 are super important. And then outlined in red, you have your B cells, which will be stimulated both by presentation of the antigen And also they can be stimulated by CD4 positive T cells to produce lots of antibody. So it's a complicated interaction. You have a lot of things going on. And it's mostly started, like we talked about, by PAMPs, pathogen-associated molecular patterns, those things that especially bacteria have that our cells don't. And because our cells don't have them, our cells should recognize them as foreign. And some of those are listed here. Teichoic acids, lipid A, which is the endotoxin component of LPS, peptidoglycan. And they bind to two receptors that are called pattern recognition receptors, PRR. So the PAMPs bind to pattern recognition receptors, and that leads to cytokine production and cytokine release. And some of those cytokines that are produced early are our really important pro-inflammatory cytokines like TNF-alpha and interleukin-1. Those help to activate that acute response. And we can also get some of the granulocytes to come in and dump antimicrobial peptides, other toxic compounds to hopefully get rid of that infection. And you'll have a localized inflammation. Again, it can vary depending on what organism it is, what part of your body it's in, your overall immune status, your overall health, how the stars have aligned. It depends on your response to the infection. So it always is going to be a little bit different, but most often you'll have that localized inflammation, that pocket of redness, swelling, pain, and heat. And again, what's happening there is the recruitment and proliferation of those innate immune cells and the release of cytokines. Mostly for bacterial infections, our phagocytic response is super important. Remember, we have those chemokines, which are a subclass of cytokine. Those serve as the chemical trigger for cells to come to the area of infection. They'll transit through the blood vessels. They'll eventually start rolling along the endothelial layer. They'll eventually attach, and then you have the diapedesis, where the phagocytic cell will come through the blood vessel to that site of infection. Neutrophils generally will come first, and then macrophages, and then phagocytic response, phagocytosis, is as we've described before. Both macrophages and dendritic cells are phagocytic cells that are professional antigen presenters. Dendritic cells tend to be even more important than phagocytic cells, and that's what initiates the adaptive response. So remember, you have to have those professional antigen presenting cells that will present the antigen on their class 2 MHC to bind to the CD4 positive T cells. And that's how you'll get the adaptive response. Okay, and so here what they're showing is an antigen that is being internalized by a dendritic cell. Dendritic means immature dendritic cell. It hasn't eaten anything yet. It recognizes this antigen through toll-like receptors or other pattern recognition receptors. And when it does, it will start to release cytokines that will recruit other cells to the area. And as this is occurring, the dendritic cell matures. It will move from the periphery, the site of the body where it encountered the antigen, into the lymph node. It can interact with CD8 positive T cells because remember, all nucleated cells will also present to cytotoxic T cells. All nucleated cells have class 1 MHC, so they can show what they've got. Antigen presenting cells can also interact with CD4 positive T cells because of the class 2 MHC. So you get the stimulation of different kinds of T cells that can lead to production of more cytokines, recruitment of more macrophages, recruitment of more dendritic cells, activation of B cells and production of antibody, and memory. So it's a cascade of interactions that occur in order to drive that response to the bacterial infection. So the B cells themselves are activated by T helper cells, the CD4 positive T cells, and will differentiate into plasma cells. And again, the major difference, if you're looking at them under the microscope, you'll see that the plasma cells look like they just have tons of ER and Golgi because they're secreting so much antibody. Basically, the entire function of a plasma cell is to produce as much antibody or protein as possible. And as we've talked about, the first antibody produced, especially in a primary infection, the first time you've ever seen the antigen, is IgM, followed by class switching to IgG. IgA we find in secretions like gastric secretions, mucosal surfaces. IgD is generally found associated only with the B cells, like as a receptor, and IgE is antiparasitic and can cause allergy symptoms. So that's the broad antibacterial response. And as we talk about some of the different bacteria, we'll talk about how they can avoid our immune system. The broad antiviral response follows a similar timeline, right? Within the first 4 days, really the majority of the response you're getting is innate. And after 6 or so days, you'll start to get that antigen-specific immune response. But what's really important with an antiviral response is you really need to have that combination of cytotoxic T cells and antibody production. With bacterial cells, like an extracellular bacterial infection, you could get away with not having CD8 positive T cells. You wouldn't need cytotoxic T cells to kill, your cells and to tell them to undergo apoptosis. But with a viral infection, you've got to have the B and the cytotoxic T cell response. So you need the cytotoxic T cells because they will kill infected cells. Well, they'll tell infected cells to kill themselves, basically. And you need B cells because they produce antibodies, and you need those antibodies to bind any free virus that's in the serum and prevent it from starting an infection in another cell. So for the antiviral antigen-specific response, you really have to have both types of cell, that CD8 positive T cell and the B cell, to have the most effective response. When we talk about viruses later in the term, we'll see that some viruses, when they infect a host cell, can release tens of thousands or hundreds of thousands of active viral particles that could potentially cause a new infection in another cell. So that's why we've got to kill as many infected cells as possible so they're not releasing thousands and thousands and thousands of virus. And we need B cells to produce antibodies to clean up anything that's floating around. One of the things that interferons can do within the cell is also to have kind of an intrinsic antiviral response to tell a cell to stop replicating. Because viruses, again, we'll talk about viruses when we talk about viruses, must infect an actively dividing cell. If a cell is not making its own DNA, making its own RNA, making its own proteins, it won't be able to make them for the virus either. So a virus has to either infect an actively dividing cell or induce a cell to divide. Either way, you need the cell to divide. So one of the things that interferons can do is maybe stop some of those processes to buy us time for the antigen-specific response. Fever, interferons, and those pro-inflammatory cytokines can also drive fever, which is a really important innate response to viral infection. Sometimes just a couple of degrees difference of body temperature makes all the difference for the activity of the virus. When we talk about coronaviruses, Most coronaviruses actually only cause cold-like symptoms because they can only replicate at temperatures lower than body temperature. So they're kind of stuck up here in the upper respiratory tract, especially in the winter, because as you inhale cool air, right, it cools those passages enough that the temperature is low enough for the virus to replicate. But if it tries to get any lower, your body's too hot, and they can't. But COVID-19, right, SARS coronavirus number 2, is a little bit different because it can replicate at body temperature. And that's why it can get in to the deeper cells. So they can be very, very temperature sensitive. So fever is important. In adults, especially in adults, we don't necessarily need to lower our fever unless it's like 106, 107 for hours. Having a 103 is uncomfortable, but your body is probably doing something important. You're not going to boil to death. With kids, we worry when it gets 103, 104 because they're a little bit more sensitive, but they can, for the most part, tolerate it too. So it's often better to let the fever run its course and not take a fever-reducing drug because that can accelerate the healing process. Phagocytic cells are capable of engulfing free virus and cell debris. A lot of times when a virus gets inside of your cell, the way it gets out is by causing your cell to burst. So phagocytic cells can also help clean up that damage. Natural killer cells and CD8 positive T cells will act to kill infected cells. Of course, natural killer cells are part of the innate system, whereas CD8 positive T cells are part of the adaptive. And then interferons can activate that immune response and enhance T cell activity. So really the idea is raise the temperature to prevent the virus from replicating, produce cytokines to prevent cells from replicating, to recruit macrophages, and to recruit those cells that will kill infected cells. So I like this card, RIP, right? Oh, sad. A viral infection will almost always, there are some exceptions, kill the host cell. But when this happens, all the active virus is released. But the infected cell can begin to express interferons, which can induce the cell to be in an antiviral state. So it will produce various enzymes, it will secrete more cytokines, it will inhibit its own protein synthesis, it will degrade mRNA to help get rid of the virus. And what they're trying to illustrate, they're saying that this virus, let's say, is influenza, right? This is going to be in your respiratory tract. This is not an immune cell, it's just a regular cell of the respiratory tract, so it will present antigen on that class 1 MHC because all nucleated cells have that class 1 MHC. So it will say, this is inside of me. This is inside of me. And eventually a cell will go, ooh, that's a problem, right? One of the T cells will come by and say, that doesn't belong. So that adaptive response, antibodies are really important because they can lead to neutralization, so they can physically block the virus from getting into the host cell. Viruses have to bind a protein on the surface of our cells to get in. Viruses are usually pretty small, so an antibody binding to a virus can often prevent that virus from being internalized by the target host cell. Opsonization is basically that signal where a phagocytic cell will say, oh, I recognize that constant region of the antibody, the feet, right? If you picture the antibody. I recognize those feet. I'm going to phagocytize this. I'm going to eat it. Virally infected cells can also be recognized by antibodies because those infected cells will start to show the antibody on class 1 MHC. But the other thing that viruses can do, there are some viruses that are what we call enveloped. They need a membrane around them. Well, where do they get the membrane? from us. They steal part of our membrane and use it as their own. But when they do that, they'll sometimes put their own proteins in it too. So our cells not only might show viral proteins on class 1 MHC, we might also start showing viral proteins in the cell membrane. And that can lead to antibodies binding. And so when that happens, natural killer cells can come in and they do what's called antibody-dependent cellular cytotoxicity. They tell the infected cell to die. And then CD8 positive T cells will also tell the cell to die. So you get virally infected, you're toast. Okay. So again, in the early stages, that innate immunity, you've got high levels of interferon, you've got high levels of natural killer cells, the viral titer, the amount of viral particle in the body, kind of peaks right here, right before this transition. And then we start to get the virus-specific CD8 positive T cells and the virus-specific antibody. Oops, wrong way. Come on. Okay, so viral escape. When we talk about viruses, we'll talk more about some of these things, but viruses can also escape the immune system. Obviously, we've all had viral infections, so viruses are able to do something to avoid our immune system. They can hide from antibody. They can change the antigens they show on the surface. They can secrete kind of their own form of an antibody that will block ours. They can block the production or action of interferon. They can impair dendritic cells and other lymphocytes. My favorite is they can decrease antigen presentation. They can basically induce the cell to no longer express class 1 MHC. Right? Because class 1 MHC is what our cells do. Hey, this is inside. And the immune system says, that's okay, oh, that's not okay. So they can turn it down. And they can inhibit inflammation. They actually sometimes secrete proteins that look a lot like cytokines that have anti-inflammatory properties. Yeah, again, my favorite is they turn down MHC. And sometimes that can actually trigger the immune system too, because the immune system's like, wait, I'm expecting MHC here and there isn't any. It's like when you have kids or dogs and it gets really quiet in the house. You're like, why is it so quiet? Is it quiet because things are going well? Or is it quiet because somebody's coloring on the walls or pooped on the floor? Probably the second part, right? Too quiet. Antifungal antibody response. The antifungal response will also include an antifungal antibody response. It is important that we have some of the granulocytes like neutrophils because they will release antifungal compounds, reactive oxygen species. Some of the unicellular fungi can be phagocytized as well. Helper T cell responses are pretty important. Notice we don't really talk a lot about cytotoxic T cells with this type of infection because for the most part these aren't intracellular, they're extracellular. So the different helper T cell responses are also pretty important. And we'll talk about fungi like, I think right before Thanksgiving. And then right after Thanksgiving, we talk about parasites. Again, with parasites, that cytotoxic T cell response is not terribly important because most parasites are not intracellular. And some of the major classes of parasites that are intracellular actually infect red blood cells, which don't express MHC at all. But helper T cell responses can be really important. Antibody can also be very important, like IgE. But parasites are really tricky because a lot of them have multiple life stages. Have some of you taken parasitology? Yeah, so you know, like, oh, there's a sporozoite, a trophozoite, a merozoite. Like, stop with the zooites. You have to have an immune response to all of them. So they're tricky because they have those multiple life stages. Or they'll do things like insist in your muscles, and it's hard to get an immune response inside of your muscle tissue. or your brain, like toxoplasma. It's hard to get the immune response in there. So there are a lot of anti-parasite evasion mechanisms that we'll talk about when we talk about the parasites, which will be right at the very end of the term. Oh, we'll talk about trichinella. Yeah. One of my favorites, well, they're not really on here. I like the tapeworms. And those of you who took if you took bacteriology lecture with me, which I don't think any of you did, there was a guy that like turned up at the ER in Fresno a few years ago that had a tapeworm that he pulled out of himself. So of course it made the news. So I'll show you pictures of that later. Not the actual process of it being pulled out, but the tapeworm itself. He was like, oh, I thought it was my intestines. I'm like, well, why'd you keep pulling? Thought it was my intestines? Hi. So some of the things that can happen when you have a parasite infection, this is specifically nematodes, so like roundworms that you might get in the gut. You get that antibody response, the IgE, and that IgE can lead to secretion of granulocytes and their anticellular compounds, so antiparasitic compounds. You can get increased mucus cell production that will hopefully like flush the worms out. But again, in the US, this is not super common, I guess, unless you work at St. Agnes Hospital in Fresno. He ate a lot of raw salmon. So if you eat undercooked meat, well, that'll be a fun section for you. And then sometimes we have patients who are immune compromised or have immune deficiencies. And we classify immune deficiencies as either primary or secondary, where a primary immune deficiency is inherited. It's something that a patient was born with. It's usually a genetic condition. And that can be very severe. So, for example, there's an X-linked severe combined immune deficiency that, as you might imagine from genetics class, and I think X-linked is most common in males, and those patients do not have an immune system. They sometimes will call it like bubble boy syndrome, because there was a really famous patient in the, I want to say 1970s, where they kept him alive until he was 12 by literally having him live in a bubble. And I think John Travolta made a movie. I was a little young even for that. I have never seen the movie, but it's a John Travolta bubble boy, you'll find it. Secondary immune deficiencies are acquired, and they can be acquired in a number of different ways. They can end up being lifelong, or they can be temporary. So an example of a type of acquired secondary immune deficiency would be infection with HIV. So human immunodeficiency virus, it kind of tells you in the name what it does. It causes an immunodeficiency. And up to this point, we do not have a cure really for HIV. And we'll talk about a couple of people who've been cured, but it's a little bit complicated. Okay. Best you can do is try to keep the viral load down, keep the viruses from reproducing, so that the patient can maintain their immune system, because this virus targets CD4 positive T cells. So it wipes out the immune system by wiping out helper T cells. But drugs can also lead to a secondary immune deficiency. I don't mean illicit drugs. Illicit drugs can also lead to immune deficiency, but I'm talking about things like chemotherapy. So patients who are undergoing cancer treatment, when they're taking chemotherapy, they will be immune deficient. Chemotherapy generally kills all dividing cells, including the cells of your bone marrow. Patients who are taking any sort of steroid will tend to be immune suppressed, because that will suppress the immune system. And patients who've had organ transplants generally take immunosuppressive drugs for the rest of their lives so that they don't reject the organ. So it keeps the immune system in check. Yes.
During COVID, I know the elderly were also considered immunodeficient.
Yes.
But that's not technically acquired. It was just because
they're old. Yeah.
Yeah. So is that a separate?
Well, and I didn't put like infants on here either. So infants are also technically considered immune deficient because they haven't ever seen anything before, and basically anything can kill them. They're very, very sensitive little creatures. With elderly patients, really what you're looking at is because the bone marrow has been started to be replaced by adipose tissue. So they're no longer making new immune cells at the level that younger people are. So they don't really, I don't know, I don't hear them usually call it like an immune deficiency. They'll say more like they're immune compromised or immune suppressed. But yeah, technically that's just, when they're like, oh, Bob Barker died. I'm like, dude, duh. I don't know why you're surprised. He was 99. Like old people, Betty White, like it happens. But yeah, with the young and the old, with the young, it's just because it hasn't had a chance to develop yet. And with the elderly, it's just because the cells get replaced. Yeah. But they would also technically, I guess, be considered, you could call them immune deficient or immune compromised. Yeah. So any other questions? It's a good point to bring up that, especially those of you who are going to practice medicine, if you have pediatric patients or geriatric patients, those are things you have to think about, that they could be at more risk for infection simply because of how old they are. But there are ways that we, as people with healthy immune systems, can try to protect those people, not only the young or the elderly, but also immune deficient patients who have, for whatever reason, immune deficiencies. We can protect them through vaccination. So vaccination, the idea behind vaccination is that a patient who has been vaccinated will generate an immune response to one or more antigens without having the infection itself. So the idea behind the COVID vaccine is we don't want you to have COVID, but we want your body to know what COVID looks like. So we'll give you a vaccine that shows you what COVID looks like. Your immune system doesn't know the difference. It just goes, hey, this doesn't belong here. So it will mount an immune response. And the idea would be that next time when you're exposed to COVID, you either are completely protected because your immune system just sees it and wipes it out before you even know, or you at least have a less severe infection. So I had, last year I got my booster right at the end of October, and COVID happened at Thanksgiving. I still don't know who to blame, but I'm side-eyeing everybody because it was everybody. Even my parents got it, like we all got it. It happened, right? I tested positive on a Friday, and by Monday night I was testing negative. I ran a fever for 1 day. I never lost my sense of smell. I never lost my sense of taste. My fever wasn't even high. It was like 101. I milked it because I'm like, y'all gave me COVID, so I'm gonna milk it. But otherwise I was fine. Would I have been as fine if I had gotten COVID without having recently gotten a booster shot? Probably not. Probably would have been sicker. Everybody else in my family was sicker. I was the only one that had gotten the booster.
So did you have the booster at that time?
I had it a month before I got sick. Yeah. Almost exactly 1 month to the day I had the booster. So I'm like, where's my new, and I gotta get my new booster, gotta get my new flu vaccine too. So it's great that it protected me, even though I think you were in my class that semester, right? Where I couldn't come to the final because I had COVID. Yeah. A few of you were in my class. Yeah. I got COVID right before finals week, and then they wouldn't let me come back for 10 days. So I missed all the finals. I mean, I'm not sad about it. I still had to grade them, but I didn't have to sit here and watch you take your final. I was fine though. I even told them, I was like, I'm negative. They're like, yeah, sorry, 10 days. Okay. So it protected me pretty well. But really the idea behind vaccination is, yes, it should protect the person who has been vaccinated, but if enough people in the population get vaccinated, it should act to protect those who cannot be vaccinated. So the first vaccines given to infants, they'll sometimes get hepatitis B vaccines right at birth, but they really don't get any other vaccine until 2 months. So you have 1-month-old babies, 6-week-old babies that are at risk for lots of infections because they don't get vaccinated until they're 2 months. Things like measles, mumps, and rubella, they don't get vaccinated until they're a year, or the flu, or whatever, right? So you protect them. You protect cancer patients who've had their immune system wiped out by chemotherapy. You protect HIV patients. You protect the bubble boy. When enough of the population is vaccinated, it makes it very difficult for the infection to take hold in the population and spread. And we call that herd immunity. I like it because it makes me think of cattle. Vaccination is also named after cows, vaca. So that's why it's called vaccination, because of cowpox. So cows, we're farmers, right? It is what it is. It stops disease transmission. But sometimes those levels have to be pretty high. Like to stop measles outbreaks, the vaccination rate needs to be something like 95% or higher. Measles is the most contagious infection that we know of. One patient infected with measles can make 12 to 16 people sick. It's the most contagious infection we know of. Vaccination is why we don't have smallpox anymore. The last patient who naturally acquired smallpox was in 1978. So it's been over 40 years since a patient got smallpox. You can find a picture of him. He's standing there like, seriously? I'm like the last person with smallpox. Y'all gonna come take my picture? But we still have vaccine preventable illnesses for a lot of different reasons. With vaccination, the idea is that we want patients to have an active immune response. The patient themselves should be mounting an adaptive, specific response to those antigens. So anytime you've gone and gotten the shot in the arm, or you've gotten, the flu mist, which they'll do in the nose, or if you got the rotavirus, which is an oral vaccine, the idea is that you should now make your own antibodies and specific T cells against those antigens. In cases where we don't have a vaccine, or it's impractical to vaccinate people, or perhaps they're immune compromised and we can't vaccinate them, we can use what are called preformed antibodies. And we can give those to the patient to help clear the infection, neutralize the toxin, or whatever. So really commonly, if you've ever been bitten by a spider or a snake and you go and you try to get antivenin, those are preformed antibodies against the toxins, against the venom. Botulism, we don't have a vaccine, so you would get preformed antibodies against the botulinum toxin. And those are often produced in horses, because horses are big, they have a lot of blood. So the reasons we do vaccination, especially that passive with preformed antibodies, we can help patients who have had a known exposure. So perhaps you're a healthcare worker and you had a needle stick injury, and the patient that you're working with has hepatitis B. They were using preformed antibodies for patients who had Ebola. I know they're working on a vaccine now, but before that. If you have symptoms of an ongoing disease like botulism, we don't have a vaccine, so we have to give you preformed antibodies to neutralize the toxin and prevent it from attacking more of your neurons. To protect immune deficient individuals, and of course to block the action of toxins or venoms, so as a therapy. So we have, again, mostly what most of us will have experienced in our lifetime is an active type of vaccination. Some of them are listed here. When we talk about vaccine preventable illnesses, we'll talk about what that vaccine really looks like. But you can have killed bacteria, you can have a subunit vaccine, a peptide vaccine, a toxoid vaccine. This is a virus-like particle that's made through genetic engineering. Attenuated mutants, live hybrids, and the newer ones, DNA and RNA-based vaccines. So there's a lot of different kinds of vaccines. We mostly have really, really robust antiviral vaccines. We have some antibacterial, and there are some antiparasitic, like a malaria vaccine, that are in development. And then you have passive immunization, mostly from horses. But there was a doctor who was working in Africa during the Ebola outbreak in 2014 through 2016. It was an American doctor. He came back, they brought him back to the US, and he recovered. So of course he now had antibodies against Ebola. So when there were a handful of other Americans that developed symptoms of Ebola and were evacuated back to the US, he donated plasma and antibodies to give to those patients to help them reduce this disease severity. And there were I don't think any Americans, especially those who were evacuated back to the States, none of them died. So it was beneficial, but there is a limit to how much human antibody you can get. So horses are a good target. When we talk about vaccines and we talk about live vaccines versus, a better term is inactivated, but sometimes people call them dead or killed. Kind of means the same thing. So there are pros and cons to both kinds. With a live attenuated, so they would never give you like, oh, I'm just gonna like inject the flu into you, right? A live attenuated would be weakened. And the benefit of that is that it is technically still a living infection. And you will mount a much better immune response to a living infection. You generally don't need booster shots because you mounted a really good immune response. These will often give mild symptoms, so you may have those nonspecific symptoms like fever, tiredness. Some of the major downsides to these live vaccines, I guess the most major downside is that sometimes a live vaccine, you'll see it at the bottom of the table, can revert back to a virulent form or a disease-causing form. And the vaccine that we associate this with the most is the polio vaccine. So there are two polio vaccines available in the US. Because polio is basically eliminated from pretty much all of the world except for a handful of countries, we give the inactivated polio vaccine. But in countries that still have natural cases of polio, we give an oral polio vaccine that is supposed to be a live attenuated, but sometimes it reverts back to a virulent form. And so if you are interested in epidemiology at all and you look at polio cases around the world, the majority of polio cases around the world are actually because of the vaccine, maybe a couple hundred. And there's anywhere from like 20 to 30 natural polio cases per year. So it can revert back to being virulent, but it does provide a much better protection. They also tend to need cold storage, so it's a lot harder to get them to places that don't have the infrastructure. With inactivated, they're easy to store, they're easy to transport, they're not gonna revert back and cause a disease. They're not zombies, they don't come back to life if they're dead. So, when you hear people say, oh, I'm not gonna get the flu vaccine anymore because I got the flu last time I got the flu vaccine, it gave me the flu. No, it didn't. But you probably felt tired and achy and maybe had a little fever because your immune system was working. So that was a good thing. I always get a little bit like, if I don't feel sick after a vaccine, I'm like, is my immune system working? Are we good? Did that work? Did you get me? Okay. But the immune response is not quite as robust. But those are great for areas where these diseases have mostly been eliminated. The chance that you're going to be exposed to polio is pretty slim unless you travel to a polio endemic region. The chance that you're going to be exposed to measles is pretty slim, but measles is alive attenuated. Okay. But either way, I have never met anybody like my age, born in the United States, who's had measles. My dad had it because he's old and he was born before there was a measles vaccine. But people my age, like, we don't get measles. People younger than me, they don't get chickenpox anymore. You get a chickenpox vaccine. So I'm going to be that old lady like back in the day when I got chickenpox, right? But now we don't have that. So having a killed vaccine, because we don't have these diseases really commonly anymore, even if you don't mount the best immune response, it's fine. So these are some of the available bacterial vaccines. And again, when we talk about these different infections, we'll talk about the vaccines. Not all of them are commonly given. At the top, the first like 5 or 6, 5? 1, 2, 3, 4, 5. I can't count. 6. The first 6 are commonly given vaccines in the United States. Diphtheria, tetanus, and pertussis, those are combined into the Tdap or DTaP. For diphtheria and tetanus, it's a toxoid. For pertussis, it's an acellular component. It's like a subunit vaccine. Haemophilus influenza type B, HIB, right? That's given to children. Neisseria meningititis, this is meningococcal disease. This is one I didn't get until I moved into the dorms. They were like mandatory for people who lived in dorms. Pneumococcal is given to children, and then the elderly, people at high risk for developing pneumonia. Streptococcus pneumoniae normally causes pneumonia. It can cause meningitis as well. There are vaccines available for these other diseases listed here: cholera, typhoid, anthrax, plague, tularemia, Q fever, and tuberculosis. But very specific. Handlers of imported fur or military personnel, you should get an anthrax vaccine. I don't handle imported fur and I'm not part of the military, so I don't need it. Veterinarians and animal handlers might get a plague vaccine. We do have plague in California. It's relatively common in the Sierra. Animal handlers in endemic areas for tularemia, we have that here too. Tularensis is named after Tulare County, which is down by Fresno. Q fever, sheep handlers. I mean, you know. Tuberculosis is not recommended in the US. We don't have endemic tuberculosis. It's, you know, wherever you have endemic tuberculosis. So we do have a handful of bacterial vaccines that are common. The others are under special circumstances. This is the classic vaccine schedule recommended for children. So those of you who have children or are planning to have children, this is what you have to look forward to. They're gonna cry, they're gonna cry, they're gonna cry, right? Every time you go get a shot. But we vaccinate, so here are some viral vaccines: hepatitis B, rotavirus, polio, influenza, MMR, varicella, that's chickenpox, hepatitis A, HPV as teenagers. So there's a lot of viral vaccines as well. Okay. And you know, as more vaccines are developed, more vaccines are added to this vaccine schedule. Again, like when I was a kid, I know we got MMR, I know we got like Tdap, DTaP, and polio, but there wasn't a chickenpox vaccine. They didn't really do hepatitis vaccines, meningococcal, HPV, right? I totally missed HPV vaccines. I'm way too old. The FDA finally opened it up and said people my age can now get them too. But for a while, it was like you had to be a teenage girl. That was it. Now they opened it up to a lot more people, male and female. So these are the vaccines that we recommend and are commonly given in the US. So just really quickly, here are a number of different viral vaccines. Again, the ones up here at the top are the ones that we typically give in the US. Down here, far less common. Military personnel, kind of weird, whatever weird job situation you have. And then these are the candidates for ideal vaccine development. And as we talk about the pox viruses, we'll talk a lot more about this. And so problems with vaccines, we talked about some of them, but immune-compromised patients can't be given a live vaccine because it could kill them. There are some side effects to vaccination. Some people can have allergic reactions. A lot of viral vaccines can be propagated in eggs. So if you have an egg allergy, you may not be able to take that vaccine. Vaccine development is at high risk and very expensive. People don't use vaccines anymore because they listen to celebrities on TV. That's the biggest problem. Okay. And again, we'll talk more about that as we talk about the different infections. So we'll pick up on Friday with staff. How fun. And I'll see you in like 10 minutes or so upstairs for lab today.